Steve Goldberg, MD, is the Chief Medical Officer at HealthTrackRx, where he leads clinical strategy and innovation in diagnostic testing. Not only does he still actively practice medicine, he brings extensive experience from leadership roles at organizations such as Quest Diagnostics, Aetna, and Humana, with a focus on population health and healthcare performance. A recognized industry leader appearing on Yahoo, MSN, Newsweek, Fox, The Daily Mail, and now DX the podcast. So excited to welcome you today, Steve.
Great to be with you, Andrea.
So we are talking about lots of things today, but what I think is fun is this isn't our first time connecting. We've had a chance before to talk about some really meaningful urgent care topics. We previously collaborated on an STI trends topic, if you remember, just within the last year alone. But this time, instead of just analyzing the data, I want to talk about a really real and specific pressure that you and I both recognize, which is that physicians face a lot of pressures in urgent care. And you've previously said that things like high-deductible plans lands urgent care in this kind of cash pay transactional space. And so based on your experience, what kind of pressure does that create for physicians today? And kind of talk us through some of those examples that you've maybe seen or even experienced yourself as you're actively practicing.
Sure. Well, it's great to be with you to have the chat. Urgent care was founded in the 70s. So we're a pretty mature organization now. And health insurance also has evolved over time where most people get insurance from an employer.
Yeah.
And most people have a high deductible health plan. And it seems that the out-of-pocket expense for an urgent care visit today is $150 to $200, which is not trivial for most people. So the setting is they're not feeling ill. Pardon me, they're feeling ill.
Yeah.
Their child is ill.
Yeah.
A little stress.
Got to
think about
just
work.
A tad.
Yeah, got to think about school.
Yeah.
So they want to get their money's worth. And it's framed really as a transaction because you don't usually have a relationship with the provider you're going to go see.
Right.
So you have your own thought about what's going on. 40% of the time, it's an infectious disease complaint. Most of the time, it's a respiratory complaint. And most people think often that antibiotics will help, regardless of what's going on. So that's the expectation they're coming in with. Now, clinicians, right, have their own pressures.
Yeah.
Visits have been stable for most urgent care provider sites at about 30, 35 per day. That's a lot of work, especially for one provider. So they're really thinking about throughput. They want to do the right thing. But if the patient comes in, for example, with an expectation for an antibiotic, even if for, say, bronchitis, where 90% of the time it's viral and the antibiotic won't help, there's a tension set up for that encounter. And that's difficult for clinicians. They want to do good throughput, and this is going to take more time to talk through. The patient has high expectations for, frankly, getting what they want, having paid $150, $200. And then the other pressure for clinicians is that feedback, which traditionally has been private to clinicians on their performance, is now very public, such as Google reviews. That creates a lot of tension in that encounter.
Yeah, absolutely. So how do you see diagnostics entering into the picture, right? If we're faced with a patient that in our minds clearly has a viral illness, but is adamant that they need an antibiotic, I mean, this is a really critical moment to be able to lean into diagnostic testing, to be able to provide that kind of more clear, even more clear, I guess, direction to the patient, right? They've gone past the point of just trusting us in that moment. They have a decision that they've made before they walk through the doors. How do you kind of see diagnostics being able to enter into that story?
Yeah, I mean, part of it is, can you back up the bus to drive an evidence-based encounter, meaning talk about other than antibiotics for someone that has a viral complaint? And can diagnostic testing help you?
Right.
And there's lots of different diagnostic tests at the office, tests for send out. But we'll just talk about diagnostics in general.
Sure.
There is evidence that people want a very specific explanation of what's going on. So to say that you have a virus alone is not often sufficient.
So just generically saying you have a virus. Right. Patients are more sophisticated than maybe they used to be, and they want to know, what virus is it?
Exactly. Is it a non-treatable virus?
Right.
Or something else that treatment is needed for? So we're finding that expectation can be met by diagnostic insights.
Interesting.
And then how you leverage the insights is really important. There are lots of models for good communication we've talked about them today in the urgent care forum we're both attending. But in general, shared decision making.
Yeah.
Where you take a breath and sit with the patient and say, look, here's my impression of what's going on. Here's the information I now have. Here's some additional information I'm going to get.
Yeah.
Here's what I'd like to do. And I'm doing it for this reason, such as I think you have bronchitis. I think it's viral.
Yeah.
I don't think it requires an antibiotic. I'm going to confirm that with additional testing tomorrow. Will that be okay with you?
Right. That extra layer of support to the conversation.
Yeah.
And it's interesting. We were kind of chatting about this even before today's episode. And in my life as a primary care physician, knowing my patients really well doesn't even change the dynamic sometimes. Then they even more so will come to you and think, well, I know my doctor really well. And if I just tell her, she'll listen to me. Now flip the script. You're in the urgent care space. I don't know this doctor. I'm going to tell them what I need and they're going to listen to me because I'm paying $150 to be here. So it's almost like no matter what setting you're in as a provider, you face these pressures. And it's just recognizing like what are the tools at our disposal that we can use to help support and augment our conversation and help with that shared decision making. So
yes. And I'll add, I think the tools are helpful. The also thing we'll want to recognize is that in urgent care today, say 15,000 sites, the majority of clinicians are nurse practitioners or physician assistants.
Right.
And some of them have had limited formal in-clinic training before they go and got the training in the setting they're now working with.
Right.
So they might be guarded, a bit reserved, maybe not as confident as they will be after they've gotten hundreds of encounters in. So they feel a lot of pressure as well.
Yeah.
And studies tell us that providers feel stress.
Oh, yeah.
When going through the conversation. So yes, diagnostics work, and yes, shared decision-making work, and the evidence shows that patients can be satisfied with that process.
Yeah, so it's a matter of kind of weaving it all together and creating the best possible patient experience, not just from a retail perspective, but truly from that clinical perspective.
Yes, yes.
Absolutely. All right, so we've talked a bit about antibiotics, but let's pause and actually ground ourselves in the actual latest data about antibiotic resistance and side effects, because I think this can really help any of our listeners that are listening in. This is a very important topic because, to your point, it's really commonly the request that patients will come in with. They'll state a symptom, but kind of in the background of their mind is, this is what I'm really hoping to get out of this visit. So as we think about the clinical and operational sides, what is the best way to educate our patients on the risks and guide them towards understanding and alignment with the treatment plan, especially if they're not going to leave with an antibiotic? What are some of those kind of key data points that we can lean into when we're having these conversations with our patients?
I think there's more and more data coming out about the caution of using antibiotics when they're not needed.
Yeah.
They can affect child learning. They can elevate children's risk of having allergy for a long time. They can put that individual at risk for a resistant infection themselves. So those are kind of personal bullets that I think can be helpful in the conversation. The larger issues that antibiotic resistance will be the leading cause of death worldwide in 2050.
Yeah.
That there are 2 million resistant infections in the United States every year, that there are 25,000 plus deaths every year because someone has an infection for which there's not a working antibiotic.
Yeah.
That's all compelling to me as a clinician and to me as a clinician leader. But at that encounter level, that's kind of broad, a bit broad for folks. So talking about the impact to them and to their children of giving antibiotics when they're not necessary, I find that works.
Yeah. And as you mentioned, the children aspect is so key because parents really do want to know that they're not going to cause harm to their children. So really leaning into that kind of pediatric data, I think is super compelling to really think about a lot more often, because that's a really large bulk of the visits as well, is sick kids, right? Kids are sick quite often.
Yeah.
And you're dealing with more than just the patient. You're dealing with the caregiver at that point. So really engaging the caregiver to the extent possible and helping them recognize the best possible path forward.
Yes. And as you and I both know, and we've studied, that a real important thing for patients and their children is to understand what is the thing they want changed as a result of the visit. And oftentimes it's two things. I want to know when I'm going to get better, and I want you to be attentive to the symptoms that I'm having.
There you go.
So oftentimes you can address both, and an antibiotic doesn't have to be part of that solution.
Right, right. And it very well may not be in lots of situations.
Yeah.
Well, this has been great. We've talked about kind of diagnostics becoming a tool that can bring clarity and even sometimes levity to conversations. And this is something you think about and live and breathe all day long. So as we wrap up, just curious what your thoughts are of kind of what the future of diagnostic testing may look like as we look forward.
I think there's going to be continuing evolution of diagnostics. Mm-hmm. There's certainly point of care testing, meaning testing that's available in the office.
Yeah.
And there's also reference lab testing where you want an answer to a question that's more complex, more involved, and it has to go out of the office because the equipment needed is more complex.
Yeah.
I think there'll be continued development in both. In addition, I think there'll be expanding direct access for patients for testing, whether it's sexually transmitted disease, respiratory evaluation, and other. We see a certain amount now that's available at commercial retail change. I think there's going to be expanding interest as well and expanding availability.
Yeah, which actually creates a recognition of a need for evolution in healthcare at large, because this is kind of a new frontier, right? Expanding home testing and kind of personal decision to just do tests on your own will absolutely change the dynamic and the frontier of how we deliver healthcare then once those results come through for that patient. So
you're absolutely right. And I think two things I'll watch for is are the tests ones that have high accuracy, that folks can count on the result being meaningful? And then the other is, are they restricted, if you will, by their own decision rules, that if somebody has something beyond really the scope of the question that the test answers, would they be steered, for example, to see a clinician?
Sure.
So, for example, a sexually transmitted infection. You can get a lot of helpful information if you're not worried about pelvic inflammatory disease.
Yeah.
So let's make sure what you're asking is just a screening test of exposure.
The appropriateness.
Exactly. And you don't have something more going on that you miss getting the needed encounter.
Yeah. Wow. A lot to navigate as we press onward. So thank you so much for joining us today.
Great to be with you today.
I'm sure we'll chat again soon.
Always. You bet.
Thanks.